That was more than generous. Thank you.
I guess maybe before we turn to the readings, does anyone from the group have any sort of questions or comments for Dr. Amar? We usually try to have some space or some degree of a space for folks to appreciate, sort of the journey and in navigating global surgery and as a trainee, which can be tough.
Sure. I will use this to put in a plug for your guys' symposium on April 1st. We will have a breakout session for anybody interested in global neurosurgery in particular. And I believe there's going to be breakout sessions for other global surgical specialties. So if you guys are interested, discussion, at least for our breakout session, will be how you can get involved and how you can start your career down that path.
Yeah, no, absolutely. Or Zach, please go ahead.
Adam, thanks so much for being here. My name's Zach. I'm one of the general surgery residents. Sorry if you hear some yelling in the background. It's bath time at our house. Prime time, 6:30. I guess before we dive into the readings, the two articles that were sent around were very like 10,000-foot view, which is great. But Alex mentioned a few countries and sort of places and projects that you've been involved in, and I'd love to hear, more specifics about that. And then specifically, I mean, I'm a trainee myself in year 6 out of 8 right now of general surgery residency. And I think one of the challenges is sometimes, and Alex and I were actually talking about this earlier today when we met, is, finding ways to get great clinical training in whatever your field is, but at the same time, finding ways to pursue some of these types of projects. And I think it's, looks like the work you've done is pretty impactful. So I'd love to hear more about it.
Yeah. So the biggest impediment, I think, being a resident is just your time. A lot of these projects do require you to have some flexibility and some free time to be able to actually work on them. But the biggest thing that you have to remember in international work is the time zones. And so a lot of times, especially as a surgical resident, you're going to be in the OR when these groups of people are going to be meeting, because either they're going to have to be up at like midnight, 1 a.m. if you're meeting with people over in Asia or anything, or they're going to have to be up even earlier if they're on like the West Coast down in Latin America. And so the times that usually the meetings are around, at least for the groups that I'm involved with, they're like 9, 10 a.m. and I'm clearly in the middle of a case at that point. The silver lining of COVID was that it showed that you can be impactful without having to travel, which is a big problem for residents to be able to find the time to be able to do that. And the fact that you don't have to actually, take 2 weeks and travel to a country to be able to do this work allows some more flexibility to be able to get involved and be able to help out. The projects that I did that were on the ground really varied. And so in my research year, I simply asked the question, what are the issues out there? What are the problems? How can we address them? Whether it's, a lot of times it's just collecting more data, and that's where all the research comes in. But sometimes it's pragmatic approaches. And so the work in Tanzania, there's actually a lot of neurosurgical involvement in Tanzania. Cornell has a hospital down there that they work with, and they've established a twinning program. And there's a lot of capacity building going on there, and it's been extremely impactful. But there's still a lot of work to do. And so what our focus was rather than on training neurosurgeons, it was training neuroscience nurses. And so we worked with their nurses there. There's a few who focus on the neurosciences, but they're not officially trained. There's no formal training. And so we actually partnered with the nursing society here, the American Nursing Society, and they have a whole course that they teach and a certification program that they do for neuroscience nursing here that's already been established. It's been proven. And so we got them enrolled in that, and then they were able to take that and start building their own certification. And we were working with the government to make sure that then they would get official government certification to allow them to work in the hospitals and have a formal setup for them to be recognized as neuroscience nurses. And that's something that a lot of times we forget, that in surgery, the least important person is the surgeon, and the most important person is everybody else that actually allows you to be able to do the surgery, from nursing to anesthesia to critical care afterwards, post-op, and the pharmacists that get you the drugs to be able to do the surgery, and the equipment that you have that's sterile, everything that leads up to the patient actually being in the OR in your hands. You can't do your surgery without them. And so a lot of the stuff falls down to that. The work I did in Senegal was just helping them build a dissection lab. We put together a proposal. We were able to find a space for them. That unfortunately fell through at the end. It was a big learning point because of funding. It was going to end up costing about $1 million USD to build this regional dissection lab that would be able to train pretty much all the neurosurgeons in West Africa. And so we tried to scale it down, and even then getting funding to build a dissection lab becomes very difficult. Even here in the US, a lot of times it's industry support. And in West Africa, anywhere else really, it's much more difficult than in the US to get industry support, because there isn't as big of a space for them to be able to, get business and build profits for the company, which is their bottom line. And then my work in Afghanistan is much more systems building. That's where most of my work has been done. Spent an entire year. I don't know if you guys know Cotter's 8 steps for change, but the first step, and if you ever want to make a change to any kind of culture or organization or anything, is building your coalition. And so we spent a year getting people on board, finding the right people to work with in Afghanistan. And this was all during the time when the US pulled out and the government collapsed. And so there were a lot of shifts that kept happening, and we had to keep changing direction. And so it's a very interesting situation that we were working through. Very difficult, but we've been able to do some good work there. And it's an ongoing project. Actually, our paper on that was one of the other ones that Alex was considering. We landed on these other 2 to discuss for today.
Thanks for sharing.
Yeah, really, really appreciate those reflections and insights. I think at least two things that stood out to me were, number one, it's, to your point, like $1 million is a lot of money to come up with for a dissection lab, but it's also, it's imagine the importance and value of that kind of investment if you're training, neurosurgeons for an entire region of Africa. And it seems, I'm struck by how often it feels like there are failures of imagination where we say how much something costs and fail to appreciate actually what a cheap investment it is to invest $1 million and have so many potentially lives saved and quality of life improved for folks. And to always look at the cost side and not to look at the benefit side, I think is often a way that's used to end conversations, unfortunately. And then I really admire the work you've done in Afghanistan with sort of being an active conflict zone. I think Zach and I try to do some work in a refugee camp that is not in a conflict zone setting, and there's just often so much red tape and political nuance and real challenges to getting anything done. I don't know if you've experienced a lot of that in Afghanistan, or how sort of you have navigated that particular aspect of it.
Yeah, Afghanistan is unique even in conflict zones because of the relationship with the US. And so a lot of the work, you have to be careful about how it's being perceived. And so the simplest thing when you're working with any group is listen to your colleagues who are on the ground there. They know the situation. They know what's safe for them to be able to do. They know what's politically allowed for them to do, what's actually feasible. And so they will tell you what they want, what they need, and you're there to support them, rather than you coming in and saying, this is what we need to do. Now, your expertise in these realms, if you have expertise in training and global work, systems building, if you have expertise in specific realm of surgery, academic training, is then to give your perspective on it. So when we came in, they wanted us just to send a bunch of equipment and get donations and send it to their newest hospital that's there that they're doing higher level neurosurgery at. And we had to convince them to take a step back, bring more people on board, neurosurgeons across the country, and then do an assessment of what their capacity is and where the needs truly are, and figure out where we can do the greatest good with the limited resources we have. And even that is very difficult, especially when you can't go there in person. And so you're relying on your partners to be able to do data collection while they're also in the midst of being overrun with cases and taking care of their own families and everything like that. So it's a delicate balance of trying to do the good, but also understanding that it's not about what you want. It's really just about what you can provide for them, and they'll guide you along the way. And it's grown due to our colleagues in Afghanistan because they want this, and they're the ones that are really driving it.
Yeah, no, I think that's such an important attitude of humility to have whenever doing any sort of work in global health equity. Before we turn to the readings, anyone else have any comments or questions for Dr. Amar, or how he's sort of his journey, how he's navigated this space? If not, I will turn it over to Will, who's very kindly offered to present or sort of summarize the first reading for us.
Hi, thanks, Alex. I'm Will. I'm an M1 at Hopkins, and I'm just going to summarize part one of the two articles that we're going to discuss today. So the first article kind of dealt with like the fact that neurological disorders and injuries affect many people, millions of people each year. And there's a significant need of neurosurgical care like worldwide, not just in high income countries. But there's a pretty wide gap in access to equitable training in neurosurgical care, and particularly in low and middle income countries. So the article referred to these as LMICs. And one of the main factors contributing to this gap is the lack of like the density of the surgical workforce. And this article kind of wanted to quantify that disparity with surveys and kind of emphasize the need for this, for the increase in neurosurgical workforce capacity. So in high income countries like Europe and North America, there is a pretty high, like standardized neurosurgical training, a high rate of standardized neurosurgical training, but there's a lot more variability in low to middle income countries. And there have been efforts to harmonize this with some success, but there are still pretty big disparities with the amount of accredited neurosurgical training programs, specifically like with the lack of dissection and surgical skills, the lack of like sustainable, cost-effective training modules, and a lack of access to sufficient research. And again, this is largely due to the lack of standardized training in low to middle income countries. So now to just move to more of like these results, essentially the article wanted to look at the barriers that to accessing neurosurgical training for medical students and trainees in low to middle income class countries versus high income countries. And they did this by essentially doing a survey, and the participants of the survey were largely skewed to the low and middle income countries. And while I think that could potentially lead to some bias, some selection bias, I do think they did a pretty good job, and some of the results are pretty profound. So just to start with some negative results, I think that they found no significant difference in ranked competitiveness for entering neurosurgical training, which is really interesting, considering that, I mean, I would assume that if there's lack of availability of opportunities, people would tend to go to less competitive programs because of that, or like be able to match less competitive programs. But they found that it was actually not a significant result. However, they did find that they found a very significant difference in weekly work hours and subspecialty training availability between low middle income class countries and high middle class income countries. So high income countries respondents reported an average fewer weekly work hours than lower middle income class respondents, and subspecialty training was reported to be more available by high income countries. So there's already that disparity that is present between the two cohorts. Additionally, they found a huge lack of neurosurgical training programs in smaller island nations and sub-Saharan Africa and Southeast Asia, having the fewest number of training programs per country. Many of the respondents from these lower to middle class countries also reported that they had to go to medical school outside of their original country, and also their specialty training, so the neurosurgical training. And actually 54.4% of the respondents indicated they did not have neurosurgical subspecialty training available whatsoever. So I think this study pretty much underscores the importance of the importance of strategically investing in neurosurgical health systems via development of local governments, and then supplementing that with country-led collaborations for specialized training of the neurosurgical workforce, because these disparities have to be reconciled in some sort of way, and these are some of the ways that the article kind of encouraged this to happen. And they also discussed the importance of surgical volume and how that ties into experience for neurosurgical training. And this was really highlighted by the pandemic, where many institutions were forced to cancel elective surgeries and restructure training. So we saw how the lack of these electives and the lack of these and the restructuring of training kind of led to less specific neurosurgical training, with residents and medical students getting less and less of this exposure. So because of this, as mentioned before, the dissection and surgical skill labs in these institutions represented a very significant barrier to neurosurgical training, which kind of mirrored the limitations seen in the pandemic in these low to middle class income countries. And finally, just to summarize the limitations that I kind of had with the study, there was a small oversized number of respondents from each individual country. I mean, the total of low to middle class income countries, there was a significant number of respondents, but per country, it was a pretty limited number. It also introduced potential sampling bias, people who responded might be more likely to respond because they have worse experiences in finding neurosurgical training, or maybe they have really good experiences finding neurosurgical training. We can't really tell. So that could lead to some bias. And it was also unclear if participants provided data from their country or from their country's training, or from individual experience they had from outside training. So I think in general, these findings are pretty significant and highlights a need to really focus in on providing these medical students and trainees coming from these low to middle class income countries with sufficient opportunities like research, surgical training, and dissection. But I think there's also some limitations which should clue you into maybe interpreting these results with some caution. And yeah, thank you.
Thank you, Will. That was fantastic. Really thorough summary, and I think gives a good sense of some of the opportunities and also the challenges in this space. I don't know, Adam, I'm curious if you have anything to add or anything from your perspective you'd like to highlight from the piece.
So the one thing I want to just mention about this study and studies like this is, you always have to take these with a grain of salt. And within global surgery research, there's this propensity to do these big 10,000-foot views of what's the global workforce, what are the global access issues. And all they really do is give you an idea of what items you really need to focus on, what potential issues are there. And so you really can't interpret any results really, because there's so much variability from country to country or even within a country. And so some of the stuff that you were talking about with these results, you can't compare LMICs to HICs really. We do some overarching comparisons to try and see, but things like the access to training, it all depends on for say dissection labs, if we have a sampling bias of people that are involved in these organizations that allowed us to get access to them to complete the survey, they probably have more of a privilege and access to these things. So you're not necessarily seeing what the reality within a country is. And you can't really necessarily do anything with this data. When you look at this, when you go to a country, then you want to revisit this and restudy it and get more granular information in order to actually do anything with it. You can't just say, oh, LMICs don't really have a difference in terms of dissection lab accessibility than HIC, so that's not an issue. We don't need to build dissection labs in LMICs. We don't need to improve mentorship in LMICs because it's no different than HIC, so it's not an issue. But if you go country to country, you will probably find differences, and even within a country. And so it's just something to pay attention to, and you have to take all this with a grain of salt.
Absolutely, absolutely. Especially humbling coming from the author of the piece itself. Curious if anyone from the group has thoughts, comments, questions, anything.
Just a small comment here. And looking at the respondents to this survey, it seemed like they were coming from many different training levels. And so medical students to, recent neurosurgery graduates. And I think, that could create a skewed view of the data when it's all lumped together. And so breaking it down, I don't think the total N would allow for robust stats, but I think it'd be worth looking at how the recent neurosurgery graduates and even neurosurgery trainees compare without more junior trainees.
Yeah, does anybody here have a lot of experience with survey studies? So it's the process for it is extremely difficult, especially once again, if you're doing it globally. The process for doing a survey is that you develop the survey, then you have to test it out within a small sample population that's going to be similar to who you're going to be sending it out to. And you're testing these questions to see what are the responses that you're going to get back. Do people understand the questions in the way that you mean for them to understand them? When you're doing it globally, you can't do that because everybody's coming from different backgrounds. You literally have to send out the whole survey, see what you get, and then resend it out after you've made adjustments. And so that's not feasible. And this is another reason why these large global studies, you have to take with a grain of salt. The different training ones, the purpose of that was to take a look at the different areas when people are entering into the training and see where the different barriers at different points. And so when we created this, medical students that were surveyed were asked specific questions. The ones regarding training, they weren't asked. Only trainees were asked. And then the ones who had graduated, they were asked specific questions. And you are right, that limits your N. And our N on this is very small, especially for a global study. There's one other study out there that looks at this done by the WFNS, where they had a lot more people and they focused just on trainees. And so their numbers are better to, and you can do a little bit more with it. But they didn't ask a lot of the questions that we did. And so there's a whole realm here for looking at this that still needs a lot of data. But as I said, it's much better to do it at a country level because it's much more actionable. The other thing with surveys is this was only done within English. We did not translate it to multiple languages. And when you're doing anything globally, you really do want to translate it. And the way that you do it is you translate it to the language, then you have it back translated to English and see how it translates. And a lot of times what you'll see is that the questions, when they're translated back, it doesn't make any sense in English. And that means that probably what you're translating to the other language is incorrect and needs to be retranslated to something that will be understood appropriately. And so surveys, there's a lot of survey fatigue now, especially after COVID, because everybody got into surveys around that time because it was the thing you can do from home when you're under quarantine. But it's a very difficult research to actually do well. And so it's something, if you guys are interested in doing, is public health, people in public health do it a lot better. And so you could always partner up with somebody from there and learn from them.
I appreciate you breaking down some of the nuances of survey studies. It certainly was an undertaking, I'm sure, to do this on such a scale that it was done.
Other thoughts, comments, or questions?
Hey, Alex, I don't have your comments or questions at this time. Hey, Adam. But I was wondering if you wanted me to go ahead and do the second article at this time.
Sure, yeah, that would be fantastic, and we can. The two are closely related, as people might have gathered from the titles, part 1, part 2. So I imagine the conversation will probably be similar regardless. So that would be wonderful, Nancy. I appreciate it.
I was gonna say it'd be hard to miss it with the part 1, part 2. But welcome, guys, and thanks for joining our journal club. So I believe, and Adam, you can correct me if I'm wrong, but the second article seems to come from the same survey, and just there are specific questions that were asked about the cost of neurosurgical training. And Will gave a good background about some of their disparities in training for neurosurgery worldwide from the findings of this particular survey. So for this part of the data that they collected, they got about a 31.3% response rate, which amounted to almost 200 responses from people. Their population that they got the data from were from aspiring neurosurgeons, meaning either med students or postdocs who are planning to apply or something like that, neurosurgical trainees, and recent neurosurgical graduates who are practicing. They got a good response from different countries, but primarily from lower middle income countries. Their response that they got, which is not exactly surprising, but different from what we're used to. So as a comparison, neurosurgical training, just like any residency training in the United States, you go to med school, hopefully you don't pile on too much debt, and then you go to residency, and as part of their GME, ACGME, or CMS, our funding, you get funded for residency. Everyone does. But it's interesting to note that there are parts of the world where instead of getting funding for your training, you're actually paying the program for your training. Obviously, you would think that places with more resources, maybe it would make sense to pay to get more training, but places with the least resources are probably where you're gonna see most people paying. They have, very nice table and figures showing the distribution of where they got their responses, as well as noting among the countries of the people that responded who was getting paid and who had to pay to participate in residency. And there was a not insignificant amount of people who had to pay. How much they had to pay ranged, obviously, but there are places in some of the African countries that were paying up to over $20,000 for their education, which may not sound like a lot here, but it is significant if you were to translate it back into the local currency. Now, one of the things that I don't think the survey comments upon is that, you can pay through several different means, right? You can pay for the education itself, but you can also pay in other ways by the fact that you're not working yourself in a separate venture that generates income. You probably are also going to have to provide your own, let's say, loops, for example, for surgical care, or you're going to have to provide other other certain stuff for your training, like educational resources, like research access for papers, for instance, if those are then for you. So even though this data mentions specifically, and again, Adam, you can correct me if I'm wrong, but even though this data mentions what is being paid as a direct cost for your residency, there are several other direct and indirect costs that may not be accounted for the survey. So for those that are paying to get the training, you can imagine that their cost burden is even higher. Additionally, for those that do get paid, there were a number of them that did not have were paid quite a low rate. Now, as residents in the U.S., we do talk about their amount that we're paid, but when you compare it to other regions, we're probably in a very lucky cohort in terms of our compensation. Now, the reason why this is all important, of course, is the fact that the workforce in African countries and other lower middle income countries is not great. So there are barriers to training, there are barriers to mentorship, research, infrastructure. And then you add on top of all of that, that people who may not have money have to pay for it themselves and end up having a practice that may in some ways not compensate for itself in the long run. It's a hard ask for a lot of people. So obviously, this is more of an exploratory survey in terms of the information that it finds. It would be useful and helpful, of course, to kind of dive a little bit deeper and see how some of these cost measures may be mitigated. As a caveat, though, in a lot of these places, people tend to also travel outside the country to seek training, whether to be able to come back to their own countries to work, which they have to cover entirely by themselves unless they get some grant funding, or they come away to, the US, Europe, or the United Kingdom to essentially do residency and practice, since that's a more viable economic option for them. This is just a brief summary that I kind of abstracted from the study, and I'll be curious to see other people's thoughts.
Yeah, thank you, Nancy. That was super helpful, and I think a really meaningful summary of the second part to it. Adam, like with part one, I don't know if there is something in particular you wanted to highlight to the group or anything to add.
I think Nancy made the point. The reason that we split this up into two papers was, one, because this aspect of the finance was such an intriguing finding, and I think so important to put out there, because honestly there really isn't any data when it comes to finances for anything medical. We're shy about talking about money, but it's a very important part, and it has enormous consequences. The other one is that it gets you a second publication and allows two students to be first authors. So it helps out people as well on our end. But I think if I could take anything away from these papers, it would be this finance aspect, and forget about the rest. The rest you can kind of figure out on your own, that things like mentorship and dissection labs and number of training programs and things are going to be fewer in LMICs. and people will have to like leave their country to go get training in elsewhere. But the financial cost is something that's crippling for them. And for those that can do it, it then creates disparities because then only the wealthy can afford to become neurosurgeons. And they're going to then cater towards the wealthy that can make up that money that they lost paying for training, or they leave their country to go work somewhere else in another country that will pay more, and now you're contributing to brain drain. And so it's a domino effect that worsens the situation. The other aspect is, as Nancy said, it doesn't seem like much to us. So if we are looking to improve training, we have to consider finances whenever we do work in other countries, because if you're going to sit there and build some new dissection lab, or you're going to give them a bunch of books or equipment, you could probably take that money would have spent on that, and training just one neurosurgeon from start to finish will have a greater impact than any of that other stuff that you're going to give. And so it's something that we need to consider in our investments, and the return on investment is tremendous if you're going to spend, say, $20,000 to train somebody from start to finish so that they don't have that economic burden.
Yeah. It's also very interesting because we also do in the US have some flexibility in terms of doing research and elective time. Like here, I'm fortunate to be able to explore some of these interests without worrying that I'm not going to get compensated, and I'd have to worry about needing to pay back more clinical time so I can get paid. Those kind of flexibilities are not there in other countries, which also has implications for their ability to have a robust research network or a robust educational network, because their time has to be spent in other clinical duties. But overall, it's important information to have and to understand what it's like in other countries.
Can I ask a question? And kind of maybe beyond the scope of this paper, but has the brain drain that you mentioned, Adam, been quantified in previous publications?
Not in neurosurgery, but there's a good literature out there for other medical specialties, brain drain and the push and the pull factors that contribute to it. And there's some really good research that's been done, survey studies with associated interviews that they did to really get at those points. And I don't know if anybody's familiar with that, but push and pull factors refer to the factors that push you to leave the country, contribute to the brain drain, and then the pull factors are ones that pull you. So a push factor would be there's no jobs for you in your country, so you get trained, but you can't get a job, and so you're going to leave that country because you need to feed your family. A pull factor would be if you go to America, your salary is going to be way more than what you could make back home, and so that's going to keep you there. And all it really takes is one push factor and one pull factor. And so something that gets you out there, and then something that keeps you out of your country, and now they've lost you forever pretty much. And so it's something definitely that within neurosurgery, there really isn't any research on it. And so there's a huge need for research on all of this when it comes specific to neurosurgery.
One thing that I can mention is we're like as part of the Duke Global Neurosurgery and Neurology Initiative, we did a survey to assess Nigeria in terms of like their research output over the past couple of decades, since like 1962 when neurosurgery was there. And one thing that was noticed is that, I mean, it wasn't like a direct measure of brain drain, but more of an indirect measure. They went through a couple of phases, and one of the push factors for them was like conflict and, political instability. And you could tell they had a phase where neurosurgery was ramping up with more research papers and stuff like that. And then they had like a recession period where essentially their growth of neurosurgery was stunted, which I imagine was the same for other specialties as well. And the research output ended up being quite anemic. And then after they came out of that phase where they were able, it was more stable, they were able to retain more neurosurgeons and train more neurosurgeons, the academic output went like, exponentially increased. So you can always imagine how, some of these factors, I don't know, who knows, maybe if I had stayed in Ghana for neurosurgical training or for medical school training, I don't know if I would have ended up in neurosurgery specifically, but would my contributions have been different if I'd stayed back home with my family? Other people that came for residency specifically, do they consider what the impact means? One argument that people might make is that, people that leave, not all of them leave and say good riddance. There are opportunities to offer bridges for collaboration between their countries and where they end up as well. But definitely an interesting question to ask, Josh.
No, absolutely. I mean, just phenomenal work, Adam. Thanks for answering those questions. I guess in thinking about how to quantify the brain drain maybe from a different angle, is there a registry of all board certified neurosurgeons here in the US? And then, with that, retrospectively looking at place of training.
Yeah, so the US, a lot of HICs actually do a good job of registers because, there's legal ramifications for that. You can't be practicing medicine without being certified. In LMICs, there's not. And so some other work that we did just trying to figure out the workforce numbers, if you look at all the research out there, it's pretty much modeling that's done to fill in all these gaps that exist because there is no official data. And so we talk about all these numbers, especially like the Lancet Commission and stuff, as if it's dogma. All of that is estimates. We really don't know how bad it is. And so quantifying it is an extremely important thing. And that's why it really comes down to doing it at a country level. And the individual factors are always so variable, as Nancy was saying, especially in volatile countries, because that's a huge push factor and it can quickly change things. And that doesn't mean that there's nothing that you can do to help. Historically, nobody does systems development in these volatile, politically unstable countries because you work with the government one day and then all of a sudden it switches. We were doing our work in Afghanistan, the Minister of Health would change like once a month. It would be a brand new person. And so how do you work with people like that? But a lot of times if you just give up and say it's not worth our effort, then you're leaving them even further in the ditch. And so there are ways to work on it, and it all starts with data collection. And trying to understand the situation and what are the factors, but that requires, very in-depth research, which these papers definitely are not, and there's lots of limitations to it. So once again, take this with a grain of salt, but use it as kind of a jumping board to looking at what you can study in these specific countries.
I can give a plug for one of my co-residents, Dr. Yang. He put out a paper about IMGs in neurosurgery and their contributions to neurosurgery in the US, which was, a pretty impactful paper. It's a different way of looking at the brain drain, but, in terms of like you can think about how these impacts would have translated if we were back in their home country, but it's certainly interesting. You can check it out. Like our Yang wrote it.
Yeah, Nancy, I think actually you told me about that paper, and I'll find it and put it in the chat for folks. Curious, other thoughts, comments, questions, either about the papers, about neurosurgery in general, pediatric neurosurgery for Dr. Mar, anything? Hopefully that's Nancy. I just put it in the chat. Hopefully that's the right piece. I think it's the same one you had in mind.
Yeah, that is the one.
Awesome. Awesome. I guess, Adam, maybe one quick question on my end is, I mean, so, you know, at the beginning of the call, you described how so much of, you know, really any successful medical care, but especially in the neurosurgery space, relies on people and systems and supply chains and all sorts of stuff outside of the OR. And, you know, these pieces certainly focus on sort of capacity development writ large, but you know, a lot of it is how can we actually get more of the surgeons trained. And I'm curious, in your perspective or sort of experience, how big, if we're using sort of the pull push factor framework, how big of a push factor is it for somebody who maybe, you know, sacrifices a lot, somehow gets together the funding, goes overseas and gets trained in neurosurgery, and then is looking to, you know, they don't want to be part of sort of the brain drain narrative. They're looking to go back home and practice. But the infrastructure isn't quite there, or it's concentrated in, you know, a private hospital in the capital city or something. And so they find themselves maybe with their hands tied behind their back because they can't, even though they want to go to the right setting, the right system isn't there to safely then practice neurosurgery. I'm curious if that, again, what your experience has been sort of with that.
Yeah, I mean, I don't know if that's quantified, but it is definitely an issue. And one point that I think it wasn't made from this paper is the difficulty in subspecialty training. So the question that we had for that to try and assess it, we ended up kind of giving up on when we wrote the survey, because in sub-Saharan Africa, subspecialty training, the way we think of it in the Western system, doesn't exist. And a lot of people will say, oh, it's, you know, there aren't enough neurosurgeons. As soon as you train more, then they'll subspecialize and they'll take our system. But if you talk to neurosurgeons in sub-Saharan Africa, they don't want our system. They have a system that's separate. Their subspecialty training is specific to technical training. And so you're trained as a neurosurgeon. They do more PEDS cases during their residency than you know, American neurosurgeons do during theirs. They're trained as pediatric neurosurgeons in their training. And when they subspecialize, they do it in terms of surgical skills. So they'll go get endovascularly trained. They'll get endoscopic training. They'll do something that's more of a technical skill, not related to a disease pathology or a patient population. And that's their system that they do. And so when you're trying to figure out what kind of subspecialty training they have, it really depends on what their system is. And so it's hard to take a look at it globally. But what that means for them when they're trying to come back and use the skills that they might have learned elsewhere is that it relies heavily on the equipment that they have. And a lot of them will go back and they can't do it. But it doesn't mean that they can't do neurosurgery. It's just how much of neurosurgery can they do. And so back to your question, it's hard to quantify what that drain is because it's not just, oh, do they go back or not, but are they utilizing their skills to the utmost when they go back?
Gotcha. No, that's super helpful and a really important nuance. Appreciate that. I am mindful of time. We have a few minutes left. Other thoughts, comments, questions?
I had a quick question. So one of the potential solutions kind of mentioned in the second paper was convincing governments to maybe, increase investment in neurosurgical training or subsidize education. And to me, it seems like that probably involves a lot of political involvement or political influence. So I was wondering, how much influence do you really have with government officials? I know you mentioned people kind of change from year to year from administration to administration. So is it possible to really have much of a political impact, or is that kind of one of the harder things to do with global neurosurgery?
We don't have any political impact, but it's once again, it falls to your colleagues within the country. And so if you look at the work, the Harvard PGSSC, if any of you guys are familiar with it, they do a lot of policy work. They do a lot of systems building, the National Surgical Obstetric and Anesthesia Planning. You can go to their website and download the files that they have in terms of hospital assessments and country level assessments and how to plan that and the frameworks for it. But when you're doing it, it's about building that coalition. And so there's some countries where there's a lot of buy-in. The vice president in Ecuador is a neurosurgeon. And so their work in there is being propelled tremendously because the guy's a physician, the guy's a surgeon, so he believes in it. And so there's a lot of political willpower behind these efforts to build it. Other countries, they might have a lot of political backing. In Tanzania, we did, but it comes down to money, and as much as we like to think that we're the center of things, we're not. Surgery, the Lancet Commission and everything, surgery is extremely important, and there's a lot of DALYs and QALYs that are lost because of surgical diseases, and it has a tremendous impact and it's worth investing. But at the same time, it is not necessarily the biggest thing, and the investment that's required for it is so great that sometimes that capital that's needed just is too much for a country to put into it. And so it makes more sense. It's easier for them to invest in vaccines or something like that, infectious disease control. The work in Afghanistan they were doing when the government fell, my wife works at the WHO. She was deployed there. She was on boots on the ground while I was working with the neurosurgeons there. And the neurosurgeons that we're working with were like, ask your wife to talk to WHO. And WHO's goal was to put food in the mouths of the people and get them paid for the work that they're doing, keep the economy of the country going, not to bring in CT scans and neurosurgical equipment. That's way low on the list. And so understanding that you're working within a system is extremely important because you are not always the most important part of that. And knowing where you fit in allows you to better advocate for policy because you don't look like somebody who's just pushing their agenda. You look like somebody who understands how you can help out and how you fit in to helping out everybody in every way.
Gotcha. That makes sense. Thank you.
And that's a plug for the Global Surgery Symposium. Dr. Keith Park would be there, and he does a ton of policy work, has met a lot of national leaders and stuff. So maybe we can convince you to come. We can talk.
Yeah, no, I'd be love to see folks there. Thanks, Zach. Appreciate you joining. Before we wrap up, Joshua, I don't know, I saw you come off camera. I don't want to cut you off if you got a question or something.
I did. I think it may have been answered already, but I just want to ask Adam. So in your experience and looking at all these surveys and the work that you've done right now, I think what are one or two like successful training programs that you have seen like across your experience, and what are some of the factors that make them successful? So just to understand, I know it's very like context dependent, but just to understand what those major factors are, and I guess within that context, how they struggle. Maybe it's a too large of a question, and I know you answered part of it in the political domain previously, but if there were anything else, yeah.
I guess it depends on what you mean by training centers. If you're talking about within like LMICs or just overall any neurosurgical training? Within
LMICs, yeah.
So the two big, I guess there's three big success stories for it within LMICs, actually a few more. but one would be in Uganda, cure hydrocephalus. So that's kind of like the gold standard that's talked about within global neurosurgery, where ETV CPC, which is a treatment for hydrocephalus, it wasn't developed, but it was perfected. And it was shown to be extremely beneficial versus shunting in resource poor settings, especially specifically for post-infectious hydrocephalus. And so they are now the #1 training center in the world for doing this specific procedure. And so people from HICs will go there to train. People from all over sub-Saharan Africa go there to train. From other parts of the world will go there and then go back to their home institutions and train it from there. And so they found something that is very much needed. They focused on, once again, like a technical skill that can have tremendous benefits. You hone it down to a science, and then you make it as easy as possible for people to come and learn it, so that way they can take it back and train others. And so the hallmark of any good training program is teaching people to be able to be teachers themselves, because then you have exponential benefits down the line. The other ones would be Cornell's twinning program in Tanzania, Duke's twinning program in Uganda. There's Fiends backed and WFNS backed training programs in like Rabat, Morocco, which has trained dozens, if not hundreds, of neurosurgeons in all across the African continent. And all of those, the factor that's important for them is that you have the resources of an HIC that is focused on what are the needs within an LMIC. And so when you have these twinning programs, it's not us from Hopkins going and saying, hey, this is how you're supposed to do neurosurgery, do it the Hopkins way. It's about how do you do neurosurgery? What are the needs that you have? What are the things that we need to focus on for your training? And then how do we support that with our resources? And then you start to build it up. And once again, they train trainers. And so they made sure the people that they were training were going to be able to go on and train more people. And then it creates exponential growth once again.
Yeah, thank you. I'll look into these like in more detail also. Thanks.
Yeah, you can look up like training the trainer models. It's usually what it's called in the research and stuff. And there's plenty of it even outside of surgery.
Brilliant. Yeah, appreciate the question, Joshua. Let me go ahead and stop the recording.